Welcome to the Deep Dive.
Great to be here.
Today we're tackling something really vital in cancer care, blood sugar. Specifically, glucose monitoring and management.
That's right. And it's crucial not just for patients who already have diabetes, but actually for everyone going through cancer treatment.
Why is that? Why the focus on everyone?
Well, there's a higher risk of developing new onset diabetes or just high blood sugar hyperglycemia during cancer treatment. And, poor control can affect treatment outcomes, increase side effects.
And impact quality of life too, I imagine. Plus, something like 20% of cancer patients already have diabetes, right?
Exactly. So it's a really significant issue. Our main source for this deep dive is the Management of Glycaemic Control in People with Cancer, guideline JBDS 17.
A joint effort from the UK Chemotherapy Board and joint British Diabetes Societies for Inpatient Care. Looks like a lot of expert input went into this.
Definitely multidisciplinary.
So our mission today, pull out the key insights from these guidelines. Understand why glucose matters so much in cancer care and what the practical steps are.
Sounds good. And like you said, a key point right off the bat is that risk isn't limited to those with pre-existing diabetes.
Right. Cancer itself, the treatments, they can push blood sugar levels up even if you've never had issues before.
Precisely. So anyone starting chemo, targeted therapy, immunotherapy, steroids, proactive checks are, they're essential.
Okay, let's get practical. Someone without known diabetes is about to start treatment, maybe involving steroids. What's step one?
Baseline tests. Before starting those glucocorticoids, the guidelines say check their HbA1c.
That gives the average sugar over a few months.
Exactly. And also a random venous plasma glucose test, just a snapshot for that moment.
Okay, baseline done. What then?
Then, at each treatment visit, check that random plasma glucose again. Keep an eye on it.
And education is key too, isn't it? Patients need to know what to look out for.
Absolutely vital. Symptoms of hyperglycemia, needing to pee a lot, maybe getting up at night.
Polyuria and nocturia, technically.
Right. Plus feeling really tired, very thirsty, dry mouth, maybe blurry vision, headaches.
Even confusion or losing weight without trying.
Yes, all potential signs. Catching it early makes a huge difference.
Now, what about higher risk individuals? The guidelines mention some factors.
Yeah, there are definitely people more prone to steroid-induced diabetes, things like pre-existing diabetes, obviously, but also family history, obesity, older age.
Being from certain ethnic minority groups or having had impaired glucose tolerance or gestational diabetes before.
Correct. Or if they've had high sugar on steroids previously or are on other treatments known to raise glucose.
So for these higher risk people, or if that baseline glucose was already a bit high, say 0.12 millimole, what's the recommendation?
Provide them with a CBG meter, a capillary blood glucose meter, so they can check their levels themselves more often at home.
Okay, makes sense. And if those home readings start creeping up, let's say they hit 12 millimole or more twice.
Then the guidelines suggest considering starting medication, typically glycoside, maybe starting at 40 millibart.
But that might need adjusting.
Oh, definitely. Especially with high-dose steroids, that glycoside dose might need significant increases, quite frequently sometimes, to keep levels in check.
And if it stays high despite that,
you need to loop in the diabetes care provider. Let them know.
What if it gets really high, say 20 millimole or more? That sounds serious.
It is. That flags a potential emergency DKA, diabetic ketoacidosis, or HHS, hyperglycemic hyperosmolar state. You need to investigate immediately.
Okay, DKA involves ketones, high glucose, acidosis. HHS is more about extremely high glucose, dehydration, but less acidosis.
Broadly, yes. Both need urgent medical attention. Really underscores why monitoring matters.
Definitely. Now, shifting gears slightly, what about folks who already have diabetes when they start cancer treatment?
Right. So for them, the main message is expect things to get trickier.
Yeah.
Your blood sugar control will likely worsen.
Especially with anti-sickness meds. Many contain steroids, don't they?
Exactly. Those antiemetics often pack a punch with glucocorticoids. So regular CBG monitoring is even more critical once they start their cancer therapy, their SACT.
Yeah. And HbA1c checks.
Every 3 months during treatment is the recommendation.
And their usual diabetes meds might need changing quickly.
Very likely, especially when starting high-dose steroids or certain cancer therapies. The goal is usually to keep that CBG between 6 and 12 millimole.
So if it's consistently hitting 12 or more,
modifications to their anti-diabetic medication regimen will almost certainly be needed.
Okay, so monitoring, that's the foundation. Let's talk management. How do we actually control these levels?
Collaboration is key here. The guidelines really stress communication between the oncology team, diabetes specialists, nurses, dietitians both in hospital and out in the community.
Makes sense. Is there a target range they aim for?
Generally, yes. Aiming for 6 to 10 millimole is ideal. Though, as we mentioned, 6 to 12 millimole might be acceptable sometimes.
But maybe looser targets for some patients.
Right. For patients receiving end-of-life care, tighter control isn't always the priority. Avoiding hypoglycemia, low blood sugar becomes more important. So maybe 6 to 15 millimole could be appropriate there.
Okay. Let's dive into this treatment-related diabetes idea more. You mentioned steroids are a big factor.
Huge factor. Glucocorticoid-induced hyperglycemia is really common, maybe affecting 30%, even up to 50% of patients on them.
And it happens fairly quickly after taking the steroid.
Typically, yeah. That rise often comes 4 to 8 hours after ingestion. So again, monitoring is crucial. Glycoside might work,
but maybe not always.
Especially with high doses or long-acting steroids like dexamethasone, insulin often becomes necessary.
And it's not just steroids, is it? Other cancer drugs can cause problems too.
Oh, a whole range of them. The guidelines list quite a few MTOR inhibitors like everolimus, PI3K inhibitors like alpelisib,
EGFR inhibitors, TKIs, ALK inhibitors. It's a long list. They work in different ways.
Yeah, various mechanisms. Some might cause insulin resistance, interfering with how cells use insulin. Others might directly affect the pancreas's ability to produce insulin, maybe even through autoimmune processes in some cases.
What about the newer immunotherapies, immune checkpoint inhibitors, ICPs?
Yes. ICPs carry a specific risk. It can be rapid onset, quite severe hyperglycemia, often presenting like type 1 diabetes, sometimes straight into DKA.
Wow, okay, so that needs urgent insulin.
Usually, yes.
Yeah.
Urgently. And the tricky part is steroids are often used to manage the side effects of ICPs.
Which then makes the high blood sugar even worse.
Exactly. It's a real challenge. If a diabetic emergency happens with ICPs, the ICP treatment might need to be paused, get the sugar stable with insulin, and then maybe restart later.
Gosh, that's complex. Now, a really interesting point you raised from the guidelines was about not lowering sugar levels too aggressively. Why the caution?
This is so important. Malnutrition is incredibly common in cancer patients, maybe 50%, even over 70% in some studies. And it's linked to worse outcomes.
Cancer, cachexia, sarcopenia, muscle loss.
Right. Plus, poor appetite, nausea, vomiting for the cancer or the treatment. All these things increase the risk of low blood sugar, hypoglycemia.
Especially for those on insulin or sulfonylureas.
Definitely. Or those with type 3C diabetes, where the pancreas itself is the issue.
But paradoxically, high blood sugar can also cause weight loss.
It can. So you're walking a tightrope. You need to manage the hyperglycemia, but you absolutely cannot compromise their nutritional status to do it.
So strict dietary restrictions to control sugar are generally a no-go.
Generally, no. The priority is to adjust the diabetes medication, not restrict food intake in a population already prone to malnutrition.
What if they need nutritional support, like feeding tubes or IV nutrition?
And you need really close glucose monitoring, because introducing nutrition can cause hyperglycemia or flip someone from hypo to hyperglycemia very quickly.
So teamwork with dietitians is crucial there.
Essential. It's probably one of those critical takeaways. Be careful not to overtreat hyperglycemia in cancer patients because the risk and consequences of malnutrition are just so high.
That really drives home the need for holistic care. The guidelines also specifically flagged dexamethasone. What was the key point there?
Dexa is potent, long-acting, and has a big impact on blood sugar.
So extra caution needed.
Yes. They mentioned potentially considering other sulfonylureas besides glycoside, depending on local practice. And remembering it can worsen ICP-induced hyperglycemia, use it cautiously in that context.
Okay, let's try and wrap this up. What are the absolute core messages, the key takeaways for listeners from all this?
I'd say number 1, vigilant glucose monitoring and proactive management are non-negotiable for all cancer patients, diabetes or not.
It's about optimizing treatment, minimizing side effects, maintaining quality of life.
While always considering their nutritional needs. That balance is key.
And early identification, prompt action.
Crucial. And that needs collaboration, oncology, diabetes teams, primary care, all working together.
So for anyone listening who's going through treatment or supporting someone who is, what's the actionable advice?
Talk to your healthcare team. Openly. Ask about glucose monitoring. Mention any symptoms you notice. Ask about the risks with your specific treatment plan.
Don't be afraid to ask what the management strategy is.
Exactly. Be proactive. The guidelines even have sample patient info sheets and referral letters showing the kind of communication that should be happening behind the scenes.
So if you're about to start chemo, for instance, make sure those baseline sugar tests get done before you begin.
Yes. That's a really practical first step.
This has been incredibly illuminating. Thanks for breaking down such a complex but vital area of cancer care.
My pleasure.
Well,
It's definitely complex, but awareness and good communication really can make a difference.
and thank you, our listeners, for joining us on this deep dive. We hope understanding these nuances empowers you, whether you're a patient or supporting one.
Absolutely.
We look forward to our next exploration together. Until then, take care.